So I'm going to discuss reentry devices. Are they all created equal, and how do we choose between them? These are my disclosures. So I think there's obviously benefits of subintimal dissections. By going subintimally, you basically circumvent the disease portion of the vessel. It provides a plaque-free space to some degree for delivery of stents, and can have improved expansion of stents potentially in the subintimal space. It provides a direct path to the reconstituted vessel distally, and it can be very quick in terms of crossing compared to trying to stay true luminally all the way through. The disadvantage is sometimes you just get to a point where you have one of these difficult reentries where it's hard to get through back into the lumen. Some of the tips to aid in reentry are listed here. The first issue is not going beyond your area of reconstitution. So when you've identified your area of reconstitution, you want to make sure that as you're going subintimally, you stop right at that spot and check to see if you're in the vessel by getting back bleeding through your catheter. If not, you need to resist the urge to keep pushing the wire further. Generally, the artery or the wire will re-enter right where you get to that non-disease segment. But if not, if it doesn't automatically do that, this is when you need to start thinking about reentry, either with a reentry device or some catheter or wire trip. Another tip is to keep that dissection plane with your looped wire small. One of the ways to do this is to use lower profile systems such as 014 or 018 wires. The command wire, for example, or any other 018 hydrophilic wire, V18, for example, are nice wires to do the subintimal dissection without getting a big J loop that a stiff glide will cause, for example. So the smaller your dissection plane, your dissection channel, the closer you are to that lumen, and the easier that reentry can be. And then finally, before going to a CTO, going to a reentry device, as we were just discussing, we can use a catheter with an angled tip with one of our CTO wires. With about a 45-degree angle on that CTO wire to try to direct it toward the lumen and pop into it without taking out one of our more expensive reentry devices. So these are some of the CTO wires on the market now, and they typically will have between 12 and 30-gram tips, and often they're tapered at the tip, and this gives you a lot of penetration power to pop into that reentry point. If these techniques don't work, there are a number of available reentry devices on the market. The Outback, Pioneer, Interior, and OffRoad are ones that are commonly used and available in the U.S. I'm going to go over each one of these real quickly. So the Outback Elite reentry catheter is 6 French sheath compatible. It comes in a couple of different lengths. You use this over an 014 wire. So essentially you get down to your area of reconstitution with an 014 wire. You bring this device over that 014 wire, and then this thumb switch activates this needle which comes out of the side of the device. So you bring it down in this fashion, and then you activate this needle, and this needle pops out into your dissection plane. The advantage of this device is I do think it's highly reliable. It's effective even if your dissection plane is somewhat large. The disadvantage is it is a somewhat bulky device. Crossing the bifurcation can be tough with this wire, and you do sometimes need a real supportive wire to do that. And it's not appropriate for tibials. This is really a device made for the SFA and popliteal. This is an example of a case where I've gotten down to the reentry point. I'm using a CTO wire with that angled tip, as I mentioned, to try to pop back into that lumen. You can see I'm trying to direct it toward the lumen, but I'm just, no matter where I approach this over here, I just wasn't able to get into this vessel with standard techniques. So brought an Outback catheter down to this level, next adjacent to the lumen here. Advance that needle. You can see the needle coming out, and then once the needle's out, you've pulled your wire back before you advance the needle, and then as you advance the needle, you'll often feel it sort of pop into the lumen, and then you advance your wire, and you can see it going down into the vessel. So now I'm clearly true luminal here with the wire. Exchange the Outback out for a catheter, shoot a picture, confirm luminal position, and then treat the vessel. The Pioneer Plus catheter is a very similar device. As you can see, it has the advantage of having IVUS associated with the catheter on the catheter, so you can actually direct the needle toward the area of flow in the lumen. So this is again a very reliable device, especially because of IVUS and a needle with several different depth settings, so you can really customize it to your dissection plane. Again, same disadvantages as the Outback. The Interior catheter is interesting. It's a pontoon-shaped balloon, so two different balloons here with entry ports on either side of this flat balloon. So one port, the proximal port here, you can see is where the wire's coming out. If you don't have if your lumen is on the other side of this flat balloon, you pull this wire back, turn it 180 degrees, and come out this other port over here. Advantage of this is lower profile, smaller dissection tracks. are generated when you pass this device, and it is useful in the tibials. Reliability, I think, is not as good as the Outback, but it can be quite helpful or useful. So here's that balloon coming down, the anterior catheter. I'm near the reentry point here, reconstitution point. You can see my wire coming down, and here I've gone through the wrong side of the balloon. My lumen is over here, or through the wrong exit point. So I pulled that wire back and redirected it toward the lumen here, and then I was able to get into this and treat this vessel. The OffRoad catheter is another device which has a balloon which inflates and directs a lancet toward the lumen. This is a lancet that has a 014 channel to allow your passage of the wire. So you inflate the balloon, it directs it toward the lumen itself, you advance this lancet, and then your wire passes through there. One of the things, as we've just already talked about, is the fact that retrograde access is obviating the need for some of these devices. And the advantage of retrograde access is you can engage flesh occlusions, you can deal with occlusions that end into collaterals, which are very difficult to deal with from above. The distal cap is often easier to penetrate than that proximal cap. The body floss technique, where you have both ends of the wire, Andre mentioned this at the beginning of his case, when you have both ends of that wire, you don't lose wire access as you're trying to drive a catheter or your balloon or whatever through. So it really helps you track devices as well as the other advantages. And it really has allowed us to obviate the need for some of these devices. This shows a distal SFA puncture, as Andre did in this case. You, of course, can use it for tibials, like the posterior tibial as well. This is an example of a somewhat high puncture of the SFA over here, or mid-thigh SFA puncture, passive wire retrograde. We're snaring the wire here, and then externalizing the treat. So I think in conclusion, avoiding large dissection planes with the 014 platform and meticulous technique improves your chances at successful reentry. The Outback and Pioneer are highly reliable devices, but they can be difficult to pass with a bifurcation due to their, or through heavy disease due to their profile. The anterior catheter is reliable if you're in close proximity to the lumen, and it's a very simple design and suitable for tibials. But all of these devices come at a significant cost. It's not reimbursed, so we're using retrograde access more routinely now to tackle these reentry problems as well as some of the other advantages. Thank you.